Dr. Mukherjee already said the four components of the syncope. So just do not forget these four components when you elicit the history. That's the most important thing. This is also what he shared already. Coming to the first initial step is to rule out an orthostatic hypotension because it's very, very simple. Reflex being the commonest one, you should also focus on that. And the last and the most important thing which we'll be interested is to rule out a cardiac syncope. Either it could be mechanical or electrical. Well, I will be discussing on these four steps. Step 1 is to differentiate syncope from other causes of loss of consciousness. Step 2 is to have a basic initial evaluation of syncope. Step 3 is to categorize the risk, and step 4 is to do other investigations if necessary. First thing, syncope versus seizure, it's such a very big topic, but I think it's the easiest thing is to follow some specific questionnaire as has been shown here. Step 2, this is the most important thing, history, examination, blood pressure and heart rate both in lying and standing posture, and third is the ECG. These three should form the initial component. I think all of us do, but the most important thing is in 2/3 of the patients, you can arrive at the initial diagnosis is just these three with a diagnostic accuracy of around 90%. And if you just keep on doing investigations, only 2 to 3% turn out to be abnormal if you do other investigations. So that makes things very, very simple. Coming to the history, the most important thing is to follow the 8P method. 8P is precipitants. Do not forget to ask about the prescriptions. Go behind the prodromal symptoms. And important thing is all of us do ask as cardiologists as palpitations. Other important 4 P's are position of the patient when he had the syncope, post-event phenomenon, and what existing diseases they have. And the last is the most important thing which is being stressed these days, to ask the witness and ask them to take a video recording then every time the patient has this problem. Well, in the process, do not forget these 5 important things which are dangerous, because as a cardiologist sometimes we may not get a good history of non-cardiac conditions, as this is something which is to be focused. I told about 1P, that is prescription. This is to de-prescribe few things. It's the most important thing in the order of preference. So tricyclic antidepressants, nitrates and alpha blockers are the most potent ones to cause postural hypotension and syncope. And do not forget the timolol eye drops, which can also cause cardiac syncope. Well, I was talking about orthostatic hypotension. We all know that. Blood pressure measurement. There are 2 things which can cause orthostatic hypotension. One is volume depletion, the other one is dysautonomia. How to differentiate between the two? Simplest thing is to see the heart rate. Heart rate, if it goes up on standing, it's going to be volume depletion. Doesn't change, it becomes dysautonomia. Then, of course, we all know the uses of ECG in syncope patient. It is mainly to differentiate arrhythmias, but the other important things, it might give a clue about the underlying condition like LV outflow obstruction or coronary artery disease, or even acute pulmonary embolism presenting as syncope. Well, presence of Brugada pattern or epsilon waves, prolonged QT, prolonged QRS complexes, pre-excitation, and bifascicular block will also give a clue to the underlying cause for syncope. The third thing which I said is to go for a risk stratification. You can use any of the risk scores. There are plenty of risk scores available in literature. This is the latest one which came in 2020. So I have chosen to do this. Apart from the basic history, ECG and blood pressure, here they have included elevated troponin T also. There are few other acronyms which are available and easy to remember. CHESS, braces, and I think the easiest one is to remember FAINT. So these are all few steps to identify the prognosis of the patient with syncope. Well, the fourth one which we are all fancied about is about the other investigations which we do, and the commonest one which we ask for is a continuous ECG monitoring. Unless there is a definitive substrate for an arrhythmia or a history suggestive of arrhythmia, using a routine Holter monitoring is of low yield. I've written the second one as negative predictive value. That basically means when the patient is on a Holter and the patient has had symptom but does not have any arrhythmia, then it carries a very good negative predictive value. Well, ILR is not necessarily needed for all the patients, but when there is a patient who is at high risk, or when the patient has been having recurrent unexplained syncope leading on to trauma, then I think ILR is of use. So depending on the frequency of symptoms and the nature of symptoms, you can choose one of these monitoring devices. Tilt table testing, I'm sure one of the speakers is going to talk. There is no class 1 indication, especially if the patient has a typical symptom of vasovagal symptom, then tilt table test is not indicated because a negative tilt table test does not rule out a vasovagal syncope. Well, as the previous speaker indicated, carotid sinus massage is one of the most important and unfortunately not followed one. Anybody above 40 unexplained syncope, this becomes a class 1 indication. It could be augmented by some pharmacological stimulation using nitroprusside or phenylephrine injections. Important is to try on both sides one after the other, and the most important thing is to do it in first in lying posture, and if that is negative, make the patient sit up and do that, because the sensitivity of the test becomes nearly 100% when the patient is sitting and you have a symptom. Use atropine if there is a cardio-inhibitory response. So presuming that there was an initial bradycardic response with carotid sinus massage, you have to rule out a vasodepressor response also by using atropine. And the last one and the most important thing is there is an entity called amnesic loss of consciousness, where the patient will not be able to recollect that he had a loss of consciousness. So many of these patients who come with giddiness might have had an LOC. It is best elicited from the witness. EP study, which we all fancy, it gives an yield of only 3%. Unless there is an MI, evidence of old scar, evidence of tachyarrhythmias and history and a biphysical block, EP is not going to augment our resources. Well, there is an entity called low adenosine syncope. This I have chosen to put because this theophylline gives a promising treatment in this group. Well, generally doing investigations apart from the 3 ones which I mentioned is not going to be very effective. Stress testing is another class 1 indication in patients with syncope if the syncope has happened during or after exertion. Routine CT brain is of no use, routine carotid Doppler is of no use unless there is a definitive head injury or there is a pointer to a cerebral lesion. Advanced cardiac imaging again is of no use. Well, these are my references, and the latest one came from the Canadian Cardiovascular Society of, it gave all my tips and tricks for approach to clinical, approach to syncope. Thank you.